Greetings. I'm Mary Fleming, Director of Long-Term Care Survey at the Oklahoma State Department of Health, and I'm here on behalf of the Department of Health and the Oklahoma Foundation for Medical Quality to invite you to join us on our journey to quality. We'll be going over the revised interpretive guidelines reflecting best practice standards for care of residents with dementia. In March of 2012, CMS initiated a campaign to improve the care of residents with dementia in nursing homes and reduce the use of inappropriate antipsychotics when caring for those residents. The goals of the initiative were to improve the quality of our interventions and practices when assisting residents with dementia, reduce the use of inappropriate antipsychotic medications when caring for those residents, to utilize the new CMS interpretive guidelines for caring residents with dementia and using best practice standards. Those new guidelines came out May 24th, 2013, and there will be 4 presenters here today to talk to you about those new best practice guidelines. They're also the guidelines that surveyors will use when they are surveying your nursing facilities in order to determine compliance measures. We are here to provide simple tools, and we've worked with you before to provide tools and worksheets to assist with adopting the new philosophies and practices. And we'll be providing and continue to provide a series of training programs on non-pharmacologic interventions and standards of dementia care. The regulation F309 is the same. It's been around since 1987. The regulation is long and it reads like this. Each resident must receive and the facility must provide the necessary care and services to attain or maintain the highest practicable physical, mental, and psychosocial well-being in accordance with a comprehensive assessment and plan of care. In addition, the facility must ensure that a resident obtains optimal improvement and or does not deteriorate within the limits of a resident's right to refuse treatment and within the limits of recognized pathology and the normal aging process. And then now we relate that to dementia. There are some definitions in the new guidelines and best practices for care, best practice standards for care that we need to talk about. And some of you that have been in the industry for many, many years, we've heard some of the talk and they say, oh, don't go over the old stuff. We've heard all this before. We know this stuff. However, there are new people getting into long-term care. We've got our aides and our CMAs and our new nurses that are graduating from nursing school. Some of this language may be new to them, and in fact, these are the best practice standards and the new language that goes with those. So I'm going to go over some definitions that are involved in the best practice standards for dementia care. One is person-centered care. We want to take care of individuals like individuals, and we want to take care of them in our homes like it is their home, because it is. So person-centered care is care that is tailored to all relative considerations for an individual, including their physical, functional, and psychosocial aspects. For example, activities should be relevant to the specific needs, interests, culture, and background of the individual. Medical treatment should be tailored to an individual's risk factors, their current medical conditions, their past histories, and details of their present symptoms. Now this is a new one and you're going to hear lots about this. There is a term called behavioral or psychological symptoms of dementia, BPSD. And this is a term used to describe behavior or other symptoms in individuals with dementia that cannot be attributed to a specific medical or psychiatric cause. The term behaviors is more general and may encompass BPSD or responses by individuals to a situation, the environment, or efforts to communicate an unmet need. What is behavior? Behavior, the definition, is the response of an individual to a wide variety of factors. It's generated through brain function and influenced by input from the rest of the body. Responses depend on many factors, including personal experience, past learning, inborn or inherent tendencies, the environment, and responses to actions and reactions of other individuals. Conditions such as dementia that affect the brain and body often affect our behaviors. Behavioral interventions are individualized approaches to a person, including direct care and activities that are provided as a part of a supportive physical and psychosocial environment and are directed toward understanding, preventing, relieving, and/or accommodating a resident's distress or loss of abilities. Dementia is not a specific disease. The last time I heard, there were like more than 100 types of dementia. It is a term for a collection of symptoms that can be caused by many disorders that affect the brain. Dementia causes significantly impaired intellectual functioning and it interferes with normal activities and relationships. Residents, individuals may lose ability to solve problems and maintain emotional control. They may experience personality changes and behavioral problems such as agitation, delusions, and hallucinations. While memory loss is common, especially with elder, but by itself it does not mean that a person has dementia. A lot of us can have memory loss at times. What is dementia? Dementia is diagnosed if two or more brain functions, such as memory and language skills, are significantly impaired without loss of consciousness. Some of the diseases we know about that can cause symptoms of dementia are Alzheimer's disease, vascular dementia, Lewy body syndrome, frontotemporal dementia, and Huntington's disease. Doctors have identified other conditions that can cause dementia or dementia-like symptoms, including reactions to medications, metabolic problems, and endocrine abnormalities, nutritional deficits and deficiencies, infections, brain tumors, anoxia or hypoxia when the brain's oxygen supply is reduced, and heart and lung problems. So very often you might have a resident with pneumonia or COPD with oxygen that has periods of dementia or chronic dementia because not enough oxygen is getting to their brain. Although common in very elderly individuals, dementia is not a normal part of the aging process. What is dementia? Individuals may have coexisting symptoms or psychiatric conditions like depression or bipolar disorder, paranoia, delusions, or hallucinations. Progressive dementia may exacerbate these symptoms. Some people are just odd, and so dementia will exacerbate those symptoms. The people have always been that way, and so dementia is just a part of the way they always were and the way they are now. Behaviors may be caused or exacerbated by environmental triggers. When it's too cold in your room, when it's too hot in your room, when you're used to going outside and you can't get outside, when you're not getting enough to eat, when you're not getting enough to drink, or when you want to go to the bathroom and you can't let somebody know. So behavior often represents a person's attempt to communicate an unmet need, discomfort, or thoughts that they cannot articulate. So when a resident is acting out, they need something and they just cannot properly communicate that message to you. So your job is to assess the resident and find out what that behavior is. There may be many behaviors, many different behaviors. Behavioral symptoms may be caused by medical conditions such as delirium, medication side effects, and psychiatric symptoms like delusions and hallucinations, and they should be considered as possible causes. So, for example, you may have a resident that has dementia, and in addition, they get a urinary tract infection, and they are suffering from delirium, which has a rapid onset, and so you will be seeing two different sets of symptoms that may appear to an untrained eye to be just an increase in confusion, but it has two origins. What is delirium? Delirium is a serious problem, and it's a serious problem in our nursing facilities. Undiagnosed delirium is an acute confused state, may have symptoms very similar to those of dementia and psychiatric disorders, but it's different. Diagnostic criteria for delirium includes a fluctuating course throughout the day of inattention, being easily distracted, and perceptual disturbances. It develops rapidly over a short period of time, within hours or days. So if somebody has a very rapid onset of dementia, it is more likely to be delirium. It has an underlying medical cause that can be identified through proper diagnostic evaluation. Causes include infection, electrolyte imbalances, or medication side effects. One of the most common causes that we see in nursing homes is dehydration and an acute urinary tract infection, also respiratory infections. Caring for a resident with dementia. A facility's approach to care for a resident with dementia must follow a systematic process in order to gather and analyze information needed to provide appropriate care and services. So if the resident can't tell you, you may have to learn that information in other ways. The resident and/or family or representative must be engaged throughout the process, and we'll talk more about that. And they are a wonderful source of information about the resident. The resident's record must reflect the implementation of the following care processes: recognition and assessment of the resident's needs, cause identification, analysis, and diagnosis of the resident's dementia, delirium, or what's causing behaviors, development of a person-centered care plan, individualized approaches and treatment, including non-pharmacologic and possibly pharmacologic treatment, monitoring, follow-up, and oversight, and a QA component that says that we do this routinely and we train all of our new people to do this so that this information becomes known to everybody in our facility so that our residents receive the highest quality of care. We would expect it. We expect it for our residents to have them feel like this is their home and they're treated with love and dignity, because this may be where we're going in the future, and we will expect it for us. So we're here to set the bar in 2013. The following 4 presentations will summarize these requirements. I'm going to turn the PowerPoint over to Chris Bundy, RN, and she's going to introduce you to components A and B: recognition and assessment, cause analysis, cause identification, and diagnosis. Thank you for listening.
Hello, my name is Chris, and I'm here to talk about recognition and assessment and cause and analysis of diagnosis related to F309. As Mary mentioned, F309, quality of care, has been expanded to include care of residents with dementia. The regulation itself has not changed. F309 still requires that a facility must provide necessary care and services to ensure residents attain or maintain their highest levels of well-being in accordance with the comprehensive assessment and plan of care. As you know, fundamental principles of care for any resident, including those with dementia, include an interdisciplinary approach. Recognition and assessment includes collecting detailed information about a resident. Facilities should be able to identify how they have involved residents and families in the assessment process to help identify resident history and preferences. The resident's record should reflect comprehensive information about the resident, including but not limited to past life experiences, a description of behaviors, preferences such as those for daily routines, food, music, and exercise. The record should reflect information about the resident's oral health, presence of pain, medical conditions, cognitive status and related abilities, and medications. It's important to determine if the record reflects the evaluation of how the resident typically communicates physical needs such as pain, discomfort, hunger, thirst, and emotional and psychological needs such as frustration or boredom. The record should reflect how the resident communicates a desire for something or to do something that he is not or cannot articulate. Does the record reflect the evaluation of the resident's usual and current cognitive patterns, mood and behavior, and if this presents a risk to the resident or others? Does the record reflect the evaluation of how the resident typically displays personal distress, such as anxiety or fatigue? This and other information enables an understanding of the individual and provides a basis for cause identification based on the knowing of the whole person and how a situation and the environment may trigger behaviors. If the resident expresses distress, staff should specifically describe the behavior in the medical record with enough detail of the actual situation to permit cause identification and individual interventions. The details of the situation should include potential underlying causes, the onset, the duration, the intensity, precipitating events, and environmental triggers, as well as related factors such as appearance and alertness of the resident. For example, noting that the resident is genuinely violent, agitated, or aggressive does not identify the specific behavior exhibited by the resident. Instead, the record should note that the resident responds in crowded, busy group activities by yelling or throwing furniture. This reflects not only a potential safety issue, but should result in the recognition that the resident should be provided alternative activities to meet his or her needs. Now let's talk about cause identification and diagnosis. This step uses the information collected about an individual to help identify potential causes of resident behavior, including the resident's physical condition, functional ability, and psychosocial status. Other potential causes of resident behavior could be environmental factors, how the resident interacts with others, and any other potential causes of behaviors and related symptoms. Staff, in collaboration with the practitioner, should identify possible risks and causes contributing to factors for behaviors, such as the presence of coexisting medical or psychiatric conditions, including acute or chronic pain, constipation, delirium, worsening of mental function, adverse consequences related to the resident's current medications, and any other condition to complete a thorough understanding of the resident's needs. The attending physician is responsible for supervising each resident's medical care. The facility must immediately consult with the resident's physician when there's a significant change in the resident's physical, mental, or psychosocial status. If the behaviors observed represent a change or worsening from the baseline, the attending physician or practitioner and facility staff are expected to consider potential underlying medical, physical, psychosocial, or environmental causes of the behaviors. Staff must make an ongoing effort to identify and document the new onset or worsening behavioral symptoms, including if the behavior presents a significant risk for adverse consequences to the resident or others. If medical causes are ruled out, the facility should attempt to establish other root causes of the behavior using individualized, holistic knowledge about the person and, when possible, information from the resident family, previous caregivers, and from direct care staff. This includes conducting a systematic analysis and consideration of the possible root causes, including but not limited to boredom and lack of meaningful activity or stimulation during customary routines and activities. Possible root causes may be anxiety related to changes in routines, such as shift changes, unfamiliar or different caregivers, a change in relationship with a roommate, change of a roommate, or the inability to communicate. A possible cause may be related to care routines, such as bathing, that are inconsistent with the resident's preferences. A possible cause may be related to personal needs not being met appropriately or sufficiently, such as hunger, thirst, or constipation. Fatigue, lack of sleep, or changes in sleep patterns may make the person more likely to misinterpret environmental cues, causing anxiety, aggression, or confusion. Environmental factors should be considered, such as noise levels, that could cause or contribute to discomfort or misinterpretation of noises, such as overhead pagers or alarms, which could cause delusions or hallucinations. Considerations should include a possible mismatch between the resident's activities or routines and the resident's cognitive and other abilities to participate in those activities or routines. For example, a resident who has progressed from mid to later stages of dementia may become frustrated and upset if he or she is trying to complete tasks but is unable to do so, such as dressing or grooming. CMS has included tools to F309 related to assessing residents with dementia. One tool, titled List of Boxes, contains boxes to utilize when conducting an informal assessment. Box 2 contains questions to guide descriptions of behavioral symptoms. Questions to ask include, what is the resident's behavior? Can you describe the behavior? What did he or she do? What did he or she say? What did you do or say? Why is this behavior a problem? What about it really gets to you or makes you upset? When does the behavior occur? What time of day? What days of the week? How often did the behavior happen in the past week? In the past month? Where does the behavior occur? Is there a particular room or setting within the facility where the behavior occurs, such as during activities, in the dining room, in the resident's own room with daily care routines? Can you recognize any patterns? Does the behavior happen at the same time every day? What happens right before the behavior occurs? Who's around when the behavior occurs and how do they react? What is the environment like where the behavior occurs? Is there a lot of stimulation such as television, noise, or people? How would you like this behavior to change? When would you consider the problem solved? Box 3 contains a checklist of factors to consider to identify potential causes of behavioral symptoms. The first section of Box 3 is related to resident-based factors. It includes the consideration of an altered emotional status, such as feelings of insecurity, sadness, anxiety, or loneliness, the lack of daily routines, and sensory deficits, such as hearing or sight. The section includes consideration of basic physical needs, such as hydration, constipation, or body temperature. Are interests and preferences not being met? What about the levels of stimulation? Is the resident overly stimulated? Is the resident stimulated enough? Other factors to consider include the resident's health issues, such as an underlying infection, and if he or she is impacted by other illnesses or conditions. Pain is another factor that should be considered. The resident's medication should be considered. Have there been changes in the resident's medication? Is the resident's medication inappropriate? Does the resident experience problems with ambulation or difficulty finding his or her own way? Does the resident get lost? What about challenges with performing daily activities of daily living, such as bathing, dressing, using the toilet, grooming, or eating? Does the resident experience sleep cycle disruptions? Section 2 considers whether or not caregivers have factors that might be involved. Are the caregiver's communications too complex? Is the caregiver's emotional tone harsh? Is he or she experiencing a high level of distress? Other factors to consider include the lack of availability, such as staffing issues, poor health status of the caregiver, and if his or her expectations are too high or too low for the resident. Are the caregiver's cultural expectations, care values, and beliefs a good fit with dementia care needs? Is the style of caregiving a good fit? What is the relationship between the caregiver and the resident? Is there a lack of education about resident diseases and behaviors? Other caregiver factors to consider include the lack of supportive networks or systems within the facility for dementia care, limited opportunities for caregiver respite, and the possibility of a strained financial situation influencing the caregiver's work performance. After these assessments and cause analysis efforts have revealed necessary information regarding the resident, meaningful care interventions can be planned and carried out. And Pam Hall is going to come and discuss the care planning and interventions. Thank you.
It's morning. Time to get up. Rise and shine.
What? Oh, good morning.
Good morning. So you need to sit up, swing your feet around, and then stand up. Let me help you. Come on.
Oh! Thank you. I need my, I can't find...
You can't find what?
I can't find my...
Miss Caputo, what? Is it your robe?
No.
Do you need to use the bathroom?
No.
Your glasses. That's it, right? You
What?
need your glasses?
Oh no. Oh no, did they break?
So what do you want to wear today? Your daughter Sue's coming to visit. So maybe you want to wear that nice blouse she bought you for your birthday? What do you think? What do you think, Miss Caputo?
I think I like
Good.
that.
I'll set out your toothbrush, and then you can brush your teeth when you're done, okay?
Okay.
And just put those on when you get done, okay?
Okay.
I'll be back in a minute.
I don't know. What? What?
You're still not dressed? Come on, Miss Caputo. I just need you to brush your teeth and get dressed, so when your daughters get here, you're ready.
My daughters are coming?
One daughter, just one. Susan. She's bringing your granddaughter.
No, you do not know. I have 4 little ones.
Yes, I
Four.
do know. You tell me
Four.
every day. A lot. But right now, there's one daughter on her way to come see you. So could you please just brush your teeth and get dressed?
No, they are not coming.
Yes, Miss Caputo, they are. I'll be back. Get dressed.
Good morning, Miss Caputo. May I come in? It's Heather. Good morning, Miss Caputo. It's Heather. May I come in?
Good morning.
Good morning, Miss Caputo.
Good morning.
It's Heather. Are you ready to get up?
Okay.
Okay? All right. Would you like for me to help you?
No.
Here you go. Swing your legs over to me. There you go. You ready? All right, here you go. 1, 2, 3. Good.
Thank you.
You're welcome. You okay?
I need my...
It's okay. Take your time.
I can't find the...
Your robe?
No.
You want your robe?
No, I can't find my...
Oh, I know what it is. Your glasses.
What?
You-
Oh!
It's okay. They're fine.
Did I break them?
They're just fine. See? Let me clean them for you. Here we are. There you go. Right as rain. There you are. Very good. Now, do you need to use the restroom?
Huh?
Do you need to use the restroom?
No.
Okay. No. What do you say we pick out some clothes to wear today?
Okay.
All right. Your daughter is coming today. Susan, would you like to wear the shirt she got you for your birthday? Or your favorite blouse?
Oh.
It's okay. Take your time, Miss Caputo. We are in no rush. This is one Susan got you for your birthday.
I think I like that.
This one?
I like that.
Okay. Good choice. Now, here are your undergarments and, of course, your purse. There we go. Now, Miss Caputo, let's get dressed before Susan comes to take you out.
Susan.
Yes, before your daughter Susan
my
comes
daughters.
to...
Are my daughters all right?
Oh, they're fine, Miss Caputo. They're great. They're just fine. I hear you are going out to a very special lunch. I think you're going out for tacos.
Oh.
Oh, yes. And maybe you'll have some chocolate cake, too.
Ooh. Let's go.
Oh, Miss Caputo, let's put your clothes on first.
Oh.
We got to
That
put some
would be
clothes on.
good. That would be good.
Yes, just let's take your nightgown off.
Okay.
There you are. Very good. I can smell breakfast now, too. It smells like pancakes. Can you smell the pancakes?
Yeah.
Oh, yeah, they smell good. All right?
Okay.
I think you're going to have a lot of fun today.
Hi, my name is Pam Hall and I'm going to be talking about the development of care plans. The care plan should include a well-defined problem statement identifying approaches, interventions, therapies, and/or medications for a specific resident. All of their individualized care should be involved. It needs to outline the goals of care with measurable objectives, timetables for individualized interventions. So when you are developing the care plan, after you've determined your individualized care for the resident, you will also then identify the individual or individuals responsible to implement each approach. The care plan should reflect baseline and ongoing details, such as the frequency for which the behavior occurs, intensity of the behavior, and duration of the common behavioral expressions for that individual resident. You also want to make sure you address on the care plan the expected response of the resident to your designated interventions. The care plan should also reflect specific goals and monitoring of all interventions for effectiveness in resident response to the interventions. Are the interventions working to target the specific behavior or expression of distress that this specific resident is exhibiting? Make sure once again that all your interventions are person-centered, specific to that resident. You can also look at the regulation guidelines under F279 on developing comprehensive care plans for more help in regard to doing your care plans. When you're talking about addressing medications on the care plan, you will need to address the indication or rationale for the use, specific target behaviors, also the expected outcomes, the dosage and duration of the medication, and monitoring of their efficiency with any adverse consequences. And if you're able, your plans for gradual dose reduction if an antipsychotic medication is being used. And Paula will talk a lot more about this in her medications during her presentation following mine. In developing the care plan, involve the interdisciplinary team along with the resident, the family, and/or representative. Review the results of the assessment and cause identification in order to develop individualized, person-centered interventions, such as non-pharmacological approaches like specific individualized activities, especially for residents who are exhibiting types of distress behavior, such as constant walking, yelling, or going through other residents' belongings. Wringing hands may be a sign of anxiety or feeling of insecurity. Relax the rules. There is no right or wrong way to perform an activity if the resident is safe. Again, you can look under tag F248 in the guidelines for assistance with activities. Anticipate a resident's behavior and prevent it if possible. Establish a structured daily routine for the resident that is predictable. Keep the resident engaged in activities of interest that match their capabilities. Sometimes just understanding underlying causes and possible triggers will help prevent the behavior. Understand behaviors are not intentional or done in spite, but they are a change in a person's ability to initiate or comprehend steps of a task or the purpose of the task. Staff, along with the physician, the family, and the resident, if possible, should determine if and why behaviors should be addressed. For example, if the behavior is severely distressing to the resident and has been unrelieved by other approaches and interventions. Individualized, person-centered approaches should be implemented to address expressions of distress. Inform the physician immediately of changes in resident behavior as they occur, such as change in sleep habits, withdrawal, or increased confusion. Involve other staff and family in care responsibilities as appropriate. Discuss stressful situations with your colleagues and supervisors and brainstorm about potential solutions. Utilize a consistent process to address behaviors that focuses on the resident's individual needs and tries to understand their behaviors as a form of communication. Talk with a resident in a calm voice. Offer no more than 2 choices. Do not use open-ended questions. Always keep it simple. Do not over-explain or discuss events that are going to happen in the future. Focus on the resident's individual needs. Attend to the resident's nonverbal communications also, such as grimacing may be a sign of pain. We hope this will help to reduce the resident's behavior expressions of distress. Several different techniques you might review are addressed in the CMS DVD series Hand in Hand for training nurse aides. Also, Advancing Excellence website has a lot of good materials. This information will also address stress reduction techniques that you can use for your staff. But mainly, understand behavior is frequently a form of communication for your resident. Thank you very much for your time, and Paula Terrell will be the next speaker.
I'm so glad you picked it out because I haven't seen it yet on anybody.
That's beautiful.
Oh,
That
is beautiful.
Cupcake sales is ending in 15 minutes.
We'll do a second coat, and that way we'll make sure that the color sets really well for you. Okay. You have gorgeous hands.
Come on, everybody. Come to the staff break room to buy some cupcakes for a good cause. They're going fast.
It's coming in. It's coming in.
coming.
It's coming in. We gotta get out of here.
Mr. Hayes.
It's coming in. We gotta go. Get ready. Get ready.
Mr. Hayes,
It's coming in.
I said
No.
sit now.
No.
Are you okay?
Yeah, Miss Orlando. Oh, it's all right. It's okay. How's your arm? It hurts. Does it hurt a little bit? All right, let's calm down a minute, and you and I will go see a nurse, okay? I don't get it. It seems to be getting worse. Well, I couldn't understand exactly what he was saying, combing, come in. But it all happened so quickly, to go from sanding a few birdhouses to pulling on Mrs. Crandall's arm so hard that it reduced her to sobbing. I called my friend at the Adult Day Center where Mr. Haynes used to go, and she said it doesn't sound like him at all.
Well, what was he like when he was there?
Well, he was calm and quiet, what you'd expect from a 66-year-old accountant.
Yes, we checked for UTI, dehydration. We looked at everything. There were 6 different incidents in the last month, all involving other residents and some involving aggression towards staff.
Okay, well, it seems there's no choice. 1 milligram of Risperdal, and let's start it today.
Excuse me.
Yeah, Lucas?
I couldn't help but overhear you talking about Mr. Haynes.
Mm-hmm.
Is it okay if I share something about Mr. Haynes?
Well, sure.
Can I grab a chair?
Certainly, yeah, come on.
Well, you know he likes to follow me around.
Yeah, we've noticed. He seems to like your company.
Well, yeah, I like his company too. But everything you're saying about Mr. Haynes, saluting young boys in uniform, wanting to take care of a young man and take his pulse. Even today, with they're coming, it all makes sense.
What do you mean it all makes sense?
One day, Mr. Haynes was helping me water the flowers up on the patio, and he got his shirt all wet. So I helped him change his shirt, and he had the exact same tattoo as my uncle. When I was younger, I asked my uncle about his tattoo. He told me it's the kind of tattoo those only medics have. My uncle was a medic at a MASH Army unit in Vietnam. Mr. Haynes was a medic.
Wait. I don't get how what happened today has anything to do with that.
I think I do. The overhead paging is like the announcements on the loudspeakers at a MASH camp during the war. MASH, the TV show?
Never.
She's so young, you probably never even saw the show.
No.
Okay, anyway. Well, if he was a medic, normally the announcements on the loudspeakers would tell the whole camp that injured soldiers were coming in. Today's reaction happened right after there was an announcement on the overhead. His reaction was totally normal when you think about it. He needed for us to go and get prepped so that we could help the injured soldiers that were coming in.
And the young guy who was here for rehab.
Well, I suppose if in his mind he was back at the age that he was in Vietnam, the guy in rehab was around the same age in Mr. Haynes' mind. So maybe Mr. Haynes wasn't doing anything but making sure that the guy in rehab was okay.
So, Lucas, what do you do if he reacts aggressively or violently when you're with him?
Mr. Haynes? He never does. He might get a little excited, but you just have to imagine you're in his shoes. Be in his world. React to his feelings. Be with him.
Makes total sense when you think about it.
You have to make a phone call. Thanks.
Okay.
Thank you so much, Lucas. I mean, that is very insightful.
Thank you, I appreciate it. Thank you. Well, we'll go back to work.
Hi, Dr. Knox. It's Julie Molina. I'm glad you're still here. We have some new insight into the behavior of Mr. Haynes. Would you consider delaying the antipsychotic med we talked about? Okay, I'll come to your office now and explain what we've learned.
Because then we could, past experiences like Again, excellent. And then we're going to drop them down to our side. We're going to stretch our necks a little bit. We're going to look over to the right. Don't force anything, just a nice, easy stretch. And as you come back to the center, then we're going to stretch over
Come
to
on
the
down to the
left.
activity room.
Very good. All right. It's okay, Corporal Haynes. Corporal Haynes, it's okay. It's okay. It's all right. We don't have to go anywhere. They don't need us today. We get to stay right here. Corporal Haynes, it's okay. We can stay here today. They don't need us today. Okay? Very good. Very good. You are doing great today, Mrs. Wilson. I just had to let you know that. And so are you. All of you are doing an excellent job today. Okay? Now we have our heads facing forward. This time we're going to drop our chins down to our chest. Very good. Let the back of that neck stretch a little bit.
Hi, I'm Paula Terrell, and I'm going to be talking about medication use in dementia and specifically about antipsychotic medications. It's been a common practice to use various types of psychopharmacological medications in nursing homes to try to address behavioral or psychological symptoms of dementia, or BPSD, without first determining an underlying cause for the behaviors. Medications may be ineffective and are likely to cause harm when given without a clinical indication, at too high a dose, without monitoring, or when given for too long after symptoms have resolved. When antipsychotic medications are used without an adequate rationale or for the sole purpose of limiting or controlling behavior of an unidentified cause, there is little chance that they will be effective, and they commonly cause complications such as movement disorders, falls, hip fractures, cerebrovascular adverse events such as CVAs or TIAs, and an increased risk of death. There are FDA black box warnings regarding atypical antipsychotics for use in residents with dementia, and they state that elderly patients with dementia-related psychosis that are treated with atypical antipsychotic drugs are at an increased risk of death compared to placebo. The FDA has also issued a similar black box warning for conventional antipsychotic drugs, and other classes of psychopharmacological agents may carry significant risks as well. If concerns are identified that an antipsychotic medication may potentially be administered for discipline, convenience, or is not being used to treat a medical symptom, it may be viewed to determine if it's being administered as a chemical restraint. CMS expects that residents or their family members or residents' representatives are involved in helping staff to understand the potential underlying causes of behavioral distress, and that they participate in the development and implementation of the care plan. Facilities should identify how they involved residents or their families or their representatives in discussions about approaches to address behaviors. Regarding potential risks and benefits of a psychopharmacological medication, including black box warnings, the proposed course of treatment, the expected duration of use of the medication, use of individualized approaches, plans to evaluate the effects of the treatment, pertinent alternatives, and the discussion should be documented in the resident's record. If the family or the representative is unable to participate in person, the facility should attempt alternative methods, such as contacting them by phone or using other electronic methods. If a psychopharmacological medication is initiated or continued, you need to determine what was the person trying to communicate through their behavior, what led to the initiation of the medication, what other approaches and interventions were attempted prior to the use of an antipsychotic medication. Was the family or representative contacted prior to initiating the medication? Was the medication clinically indicated? Was it necessary to treat a specific condition and target symptoms as diagnosed and documented in the record? Has the medication been adjusted to the lowest possible dose to achieve the desired effects? Has the resident received gradual dose reductions and behavioral interventions in an effort to discontinue the medication? Was the interdisciplinary team, including the physician, involved in the care planning process? Does the staff monitor for effectiveness and possible adverse consequences? There is new guidance at F329, unnecessary medications, in Table 1 for the use of antipsychotic medications. There are two different areas that list the indications for use of antipsychotic medications. The first one in A is conditions other than dementia. And it says that antipsychotics should only be used for the following conditions or diagnoses as documented in the record. These include schizophrenia, schizoaffective disorder, schizophreniform disorder, delusional disorder, mood disorders including bipolar disorders, severe depression refractory to other therapies or with psychotic features, psychosis in the absence of dementia, and medical illnesses with psychotic symptoms such as neoplastic disease or delirium, or treatment related to psychosis or mania. Also, Tourette's disorder, Huntington's disease, hiccups, and nausea and vomiting associated with cancer or chemotherapy. The second group is for behavioral or psychological symptoms of dementia, or BPSD. And they tell us that antipsychotic medications are only appropriate for elderly residents in a small minority of circumstances, unless the antipsychotic is prescribed to treat previously diagnosed mental illnesses such as schizophrenia or possible other conditions listed above. The FDA has warned healthcare professionals that both conventional and atypical antipsychotics are associated with an increased risk of death in elderly residents treated for dementia-related psychosis. All antipsychotic medications carry an FDA black box warning. A black box warning means that medical studies indicate the drug carries a significant risk of serious or even life-threatening adverse effects. It is the strongest warning that the U.S. Food and Drug Administration can require a pharmaceutical company to place on the labeling of a prescription drug or the product literature describing it. Antipsychotic medications may be considered for elderly residents with dementia, but only after medical, physical, functional, psychological, emotional, psychiatric, social, and environmental causes have been identified and addressed. They must be prescribed at the lowest possible dose for the shortest period of time and are subject to gradual dose reductions and re-review. Antipsychotic medications in persons with dementia should not be used if the only indication is one or more of the following: wandering, poor self-care, restlessness, impaired memory, mild anxiety, insomnia, inattention or indifference to surroundings, sadness or crying alone that is not related to depression or other psychiatric disorders, fidgeting, nervousness, uncooperativeness that could be refusing care. All of the above highlight conditions or diagnoses where antipsychotic medications may possibly be appropriate, but diagnosis alone does not warrant the use of an antipsychotic unless the following criteria are also met. And the first one is that the behavioral symptoms must present a danger to the resident or others. And one of the following also has to be met. The symptoms are identified as being due to mania or psychosis such as auditory, visual, or other hallucinations, delusions, paranoia, or grandiosity, or behavioral interventions have been attempted and included in the plan of care except in an emergency. When the antipsychotic medication is initiated to treat an emergency situation with an acute onset or an exacerbation of symptoms that cause an immediate threat to health or safety of residents or others, the use must meet the above criteria we've already talked about and all of the following. The acute treatment period is limited to 7 days or less, And a clinician, in conjunction with the interdisciplinary team, must evaluate and document the situation within 7 days to identify and address any contributing and underlying causes of the acute condition and verify the continuing need for an antipsychotic medication. If the behaviors persist, pertinent non-pharmacological interventions must be attempted unless clinically contraindicated and documented following resolution of the event. Antipsychotic medications may be used to treat enduring conditions that are non-acute, chronic, or prolonged, if the condition or diagnosis meets the criteria in B above. And you'll remember that Section B is related to residents with behavioral or psychological symptoms of dementia. In addition, before initiating or increasing an antipsychotic medication, the target behavior or behaviors must be clearly and specifically identified and documented. Monitoring must ensure that the behavioral symptoms are, 1, not due to a medical condition or problem that can be expected to improve or resolve. This could be related to pain, fluid or electrolyte imbalance, infection, obstipation, medication side effects, or polypharmacy. 2, not due to environmental stressors alone that can be addressed, such as an alteration in the resident's customary location or daily routine, unfamiliar care providers, hunger, thirst, excessive noise for that individual, or inadequate or inappropriate staff response. 3, not due to psychological stressors alone that can be expected to improve or resolve as the situation is addressed. Things such as loneliness, taunting, abuse, anxiety, or fear stemming from misunderstanding related to the resident's cognitive impairment. 4, persistent. There must be clear, documented evidence in the medical record that the situation continues or recurs over time or persists, and that other approaches have failed to adequately address the symptoms, and that the resident's quality of life is negatively affected by the symptoms. For new admissions, the facility is responsible for pre-admission screening for mentally ill and intellectually disabled individuals and for obtaining physician's orders. The facility must reevaluate the use of antipsychotic medications at the time of admission and/or within 2 weeks of admission at the time of the initial MDS assessment, and consider whether or not the medication can be reduced or discontinued. The treatment should be at the lowest possible dose to improve the target symptoms being monitored. There is a table provided as a general guide for residents with dementia who have met all of the criteria outlined above. It is important to not only evaluate the ongoing effectiveness and the potential adverse consequences of the medication, but to also evaluate the use of any other psychopharmacological medications, for example, mood stabilizers or benzodiazepines that may be being used. And it's also important to identify why you added or switched from an antipsychotic medication to another category of psychopharmacological medication. After initiating or increasing the dose of an antipsychotic medication, the behavioral symptoms must be reevaluated periodically, at least quarterly, but often more frequently, to determine the effectiveness of the medication and the potential for reducing or discontinuing the dose based on target symptoms and any adverse effects or functional impairment. The facility assures that residents are monitored for adverse consequences, such as general consequences that might include anticholinergic effects, falls, or excessive sedation. Cardiovascular consequences such as cardiac arrhythmias or orthostatic hypotension. Metabolic consequences, which could be an increase in cholesterol and triglycerides, or unstable or poorly controlled blood sugar or weight gain. Or neurologic consequences, which could be akathisia, neuroleptic malignant syndrome, Parkinsonism, tardive dyskinesia, CVAs, or TIAs in individuals with dementia. If the antipsychotic medication is identified as probably causing or contributing to adverse consequences, the facility must act on this. The facility and prescriber must document the rationale for the decision, and also that the resident, the family member, or the resident's legal representative is aware and involved in the decision to continue the medication.
Hey, what time you got, Arthur? 10 minutes. It's almost that time.
Oh, thank goodness. If you told me it was 1, I think I'd just collapse. I'm so beat.
Kind of like yesterday, huh?
And the day before that, yep.
I have to go home.
It's your turn.
Sorry, I was here till 3:30 with her yesterday.
Come on, Cindy. It's my day to pick up my kids from daycare.
Well, every day is my day to pick up my kids. See you tomorrow, Arthur. Have fun.
I need to go home. I need to go home. I need to go home. I want to go home. It's time. I want to go home. I want to go home. It's time. They'll be waiting. I want to go home. I need to go home. I want to go home.
Okay, let's go.
Oh, I need to go home. I need to go home now.
Miss Caputo, you are home. You live here now.
No, it's time. My children, they're there. They're going to need
Miss
their
Caputo, your
dinner.
children are grown. They don't even live around here anymore. Hey, there's a movie playing. You like movies, right? I bet there's a great movie playing. Let's go see the movie.
No.
Yeah, let's go see the movie.
I have to go home
Miss
now.
Caputo, you live here now.
I do not live here. I do not live here.
Miss Caputo.
I do not live here.
Miss Caputo, you live here now. Let's go see the movie.
I don't live here. I want to go home. I want to go home. I don't live here.
Let's go. Yeah, you're not going anywhere. Now you're just going to go to your room, okay? You're going with me now, all right?
What are you still doing here, Arthur? You get off at 3, don't you? Just go. I got her.
You can have her. I'm out of here.
All right. Let me help you with this.
Can you help me go home? I don't like him.
I was looking all over to give you your snack anyway. You ready?
I really need to go home.
I understand, Mrs.
Go
Caputo.
home. I want to go home.
All right. All right.
I want to go home.
Hey, Mrs. Caputo. It's me, Gloria.
I need to get home.
Yes, I understand.
I need to get home now.
Mrs. Caputo, I just came to give you your purse.
Okay. I need to go home.
The painting class is about to start. Why don't we go see? We need you.
No, I need to go home.
You know, I need some fresh air. May I walk with you?
Okay.
Okay.
Okay. I need to go home.
Let's walk. What a beautiful day. The sky is so blue. Look at the pretty roses. I love that color. Do you?
Yeah, I like it.
What color is that? Rose?
Yeah.
Red?
Yeah, red, yeah.
Oh my, it's almost time for dinner. Are you hungry?
Yes, I am hungry.
I know they're serving lasagna tonight. Lasagna's my favorite.
Lasagna is my favorite.
You want to get some lasagna?
Okay.
Oh, good. All right. Tell me about your daughters.
My daughters. I have 4 little girls.
Hi, My name is Michelle Rainey, and I'm going to quickly talk to you about monitoring, follow-up, and quality assessment and assurance. As you can tell from listening to the previous speakers, it takes a lot of time, education, teamwork, patience, planning, and above all, caring in order to take adequate care of a resident with dementia. To meet the requirements concerning the monitoring and the follow-up of care plan implementation, surveyors will evaluate whether or not the interdisciplinary team reviewed the resident's progress towards meeting the care plan goals, adjusted interventions when it was necessary, and identified when the goals were met. This entire process must be documented well enough to show why you did what you did, all the way up to why you are doing what you are doing now to help that resident. Your documentation has to tell a complete story, not just bits and pieces here and there. There must be clear communication with the physician or his or her designee in order to adjust some interventions based on the effectiveness or any adverse consequences resulting from them. If concerns are identified related to the resident's medication regimen, then the physician must be notified as soon as possible to initiate a change in care. If the physician does not provide a timely and appropriate response, staff must contact the medical director, and he or she must respond and intervene. It is now more important than ever to educate your physicians about the regulations and help get them on board with this new initiative. If you receive a physician's order that is not in the best interest of the resident and not according to current standards of practice, you will have to remedy the problem in some way, or you could end up with several serious deficiencies that could be actual harm deficiencies or worse. But more important than deficiencies are the residents in which all of this can affect. In regard to the Quality Assessment and Assurance Committee, QAA for short, the medical director and the committee can help the facility evaluate the current strategies for coordinating care of a resident with dementia and ensure the policies and procedures are up to date according to current standards of practice. If you are having problems with a resident or multiple residents who have dementia, then the QA&A team should be involved. In fact, they should monitor the resident care policies and see if they reflect the overall approach to the care of residents with dementia, including a clearly outlined process for their care. They should find out how the facility monitors the staff to see if they are following pertinent policies and procedures in choosing and implementing individualized interventions for the care of each resident with dementia. They should also monitor and oversee whether the facility has trained staff in how to communicate with and address behaviors in residents with dementia and find out if the trainings were evaluated for effectiveness. They should monitor and oversee whether there is sufficient staff to implement the care plans for residents with dementia so that medication is not used instead of pertinent non-pharmacological interventions. They should monitor and oversee whether staff collect and analyze data to oversee the pharmacological and non-pharmacological interventions used to care for residents with dementia. All of this plays a vital role in taking care of residents with dementia and making their lives more comfortable and more meaningful. This concludes the monitoring and follow-up and QA&A portion of this presentation.
Again, we want to thank you so much for participating in this presentation. We want to thank you for joining us on our journey to quality and for being involved in our partnership to improve dementia care in our Oklahoma nursing homes. Have a great day.